presynaptic receptors in the dorsal horn, and they will block the synaptic transmission in the axonal terminals, and mainly trigeminal, to reduce the trigeminal vascular neurons and make them less active. Okay, we will discuss this muscular pain in the occipital region because of extracranial things. And everyone, please welcome my elder brother, Dr. Ramesh Patel from Ahmedabad. He has decided to join us as well today, so it is kind of an honor for me. Please welcome him. Thank you. Okay, so next we'll talk about his cluster headaches. They are not as common as migraines or the stress headaches, for example. Only 1 in 1,000 people are affected, but they have a higher preponderance in males than females, 6 to 1 ratio. The cycle is about 1 to 4 months, but they can also have remissions that can last for 6 to even 2 years, 6 months to 2 years. So about 10 to 15% would last for over a year, but most of them don't. They usually affect unilaterally, again, eye, temple, and maxilla, the facial features are mainly affected, and mostly it is more like a facial pain rather than occipital or headache, central headache. The headaches will last for about 15 minutes to 2 hours, and they can happen even up to 4 times a day. So they are quite excruciating, and there is lacrimation, ptosis, and nasal stuffiness. Basically, it is more like a sympathetic overactivity at that point. So the treatment, as we can figure out, would be basically to block the sympathetic fibers. The prophylactic treatment is with verapamil between 240 to 430 milligrams is considered to be the first line of treatment. It may be combined with prednisone or other preparations to reduce the vascular dilatation. 1 milligram every at night. Lithium 300 milligrams per day in divided doses is also considered to be very effective. Methotrexate 2 to 8 milligrams per day, not as commonly used. More commonly used is verapamil and lithium. The episodic cluster, when it happens, prednisone 40 milligrams in a tapering dose can cut down the frequency of the episodes. And when the patient has acute episode, you want to give them more oxygen so that the sympathetic overactivity that has reduced the blood flow will increase oxygen level to compensate for the blood flow that is reduced. Arbutamine, when the blood vessels are dilated, of course, it will help. Triptans the same way. Lidocaine nasal spray or even IV. In the nasal spray, lidocaine, it will block the spinopalatine ganglion, postganglionic nerve endings, and thereby reduce the sympathetic input. So spinopalatine block, if anyone can do that, that is actually very effective for the patient's acute episode and can abort the episode as well. Then we come to chronic attention type headaches. So NSAIDs are very useful. Let me talk a little bit more about this tension type headaches. So like the example I gave you initially, that any stress, emotional or physical, can lead to muscular spasms of the skull muscles. For example, if you divide the muscles into 3 groups, the frontal, temporal, and occipital groups, any 1 or 2 of these groups can go into spasm with any kind of stress. So some people may have temporal and occipital headache. Some people may have frontal temporal headache. Some people may just have occipital headache. One of the reasons for occipital headaches is also that the trapezius muscle is attached to the cranium, and so the attachment encompasses the occipital nerve from the trapezium between the trapezius ligament. So if the trapezius muscle goes into spasm, and there could be several reasons for that. For example, if someone has a cervical disc degeneration, what will happen? The disc height will go down, which means the facet joints are going to be narrower. When the facet joints are narrower, then the patient will have start having facet joint pain. They'll have increased pain with extension or rotation like this, or even lateral bending. The facet joints will become painful. And to protect the facet joints from giving you pain, the muscles around the neck are going to go into spasm. And so trapezius being the major muscle will also go into spasm. And it will develop, if it doesn't relax properly, or if steps are not taken properly to relax the muscle, then trigger points will develop, which is part of the muscle that does not relax and becomes a painful tender spot. And if it happens to be long term, the occipital nerve will also get compressed, and then patient will have tingling and numbness type of headache and burning, shooting type of headache in the occipital distribution, which will stop at the hemicranium right here and mainly affecting the side where there is more pressure. So to treat that, what you want to do is you want to reduce the base or the cause of the pain, which is if the patient is in a habit of reading the book, for example, like this all the time, then there is more compression of the cervical disc, more irritation of the facet joints, more spasm of the trapezius. So that can not be increased, but you can reduce the pain from the facet joints. So you can either, if it is a patient is younger, you can do steroid injections and then have them do physical therapy to increase the range of motion, relax the muscles. But if they are older, then you can do frequency of the facet joints that are the cause of this pain, which will help in reducing the headaches indirectly by reducing the spasms of the trapezius muscle. So just to treat the occipital headache, if someone says that you do radio frequency of cervical facet, that will make sense because facets are the main cause for this whole sequence of events. So when the facets become pain-free, the muscles don't go into spasm, then the occipital nerve doesn't get pinched, and the patient doesn't have a occipital headache, which might be the first presenting sign. The muscle relaxants may help acutely because basically muscle relaxants are mainly CNS depressants. So the patient will they are sedated. So when someone is sedated, as we know, when we are sedated, the muscle tone will go down. Just like when we are sleeping, our muscle tone goes down. So when the muscle tone goes down, the muscle spasm also gets lower. So that is how the muscle relaxants work. Benzodiazepines work the same way by relaxing the muscles. Butal, their combinations are available. Opiates are carefully controlled because they do cause rebound headaches and habituation as well. So you want to carefully control how much opiate you use for acute headaches. And if you do use it, explain to the patient that the opiates are only for short-term use and they are not supposed to be continued for long-term. Biofeedback to relax the muscles is a very effective therapy. And let me tell you, giving my example, during my fellowship, I was trained in biofeedback by our psychologist who was very, very knowledgeable. And what he did was he brought a bucket full of ice and he put my right hand inside the ice. So initially it just feels cold, it doesn't hurt as much, but then gradually it starts getting painful. And what he also did was he put some sensors on my forehead, on the temporal area and the occipital area, and they were monitoring the muscular outflow, activity outflow, and show it on computer screen. So there were two circles, one is red, one is green, and the red is inside the green, which means the muscles are relaxed. So when the muscles start getting tense, although I had no problems with my head or any extra or intracranial problems, just my hand getting cold and causing pain had increased the stress in my occipital and temporal muscles. So those circles started getting bigger. So the red circle got bigger, and bigger than the green circle, and went outside the green circle, and that was a sign that the muscles were going to tension. So he taught me how to gradually relax the muscles by basically reversing the sensation of pain on my hand. And if one is trained properly, you can train yourself, and you can gradually start feeling warm in your hand. You can increase the sympathetic blockade in a way to cause dilatation in your hand. And as the pain goes down, the muscles in the head will relax. And that is how the biofeedback works. So any tension that causes the muscles to go into spasmodic activity can be reduced by biofeedback, and thus tension relief can get better. Strengthening exercises will tone up the muscles, of course, so they would not go into spasm and they would not create trigger points. Stretching of the muscles is very effective. Next, we will talk about trigeminal neuralgia. Usually begins after the age of 30. As you know, trigeminal nerve is number 5, cranial nerve number 5. So V2 is more common, which is the maxillary. Mandibular V3 in second most, and V1, which is ophthalmic branch, is the least common of the trigeminal neuralgia. There is intense pain with even trivial stimulation in the nose or mouth, and the paroxysmal symptoms can last for 10 to 30 seconds. And it is described as a lancinating pain, just like the lance going through your front of the head. And that is the hallmark pain description for trigeminal neuralgia. Chronic irritation of the trigeminal pathway is culprit. MRI can show what causes the pain, and particular attention to gastral ganglion is irritated by an artery. And Tegretol is the first line of treatment, 200 to 600 milligrams per day. Dilantin or baclofen can also be used. So if you look at the trigeminal, several branches that show out and cover the facial skin. From the mandibular branch, you can see temporal, zygomatic, buccal branch, mandibular proper, and the cervical branch as well. From the ophthalmic branch, you have supratrochlear, supraorbital, auriculotemporal, and from the maxillary branches, then you have zygomaticotemporal, infraorbital branch, and the buccal branch. The buccal branch actually is mandibular. So this is the distribution of the 3 branches and the different branches of the main trigeminal, 3 branches of trigeminal. So trigeminal should be multidisciplinary. It cannot just be interventional. It also has to be medications, biofeedback, relaxation therapy, and sometimes you might even have to include the family in treatments of these problems, so the family can understand what the patient is going through. Various treatment options and the risks should be discussed with the patient. The first treatment of choice is carbamazepine, Tegretol, or oxcarbazepine. In younger patients, the first choice of invasive treatment is microvascular decompression, and that is done surgically, even done with an endoscopy through the posterior approach. And they usually, I'll show you some pictures how it is done. And for elderly patients, radiofrequency of gastral ganglion or trigeminal ganglion is recommended. If I have to use radiofrequency for younger patients, I always use pulse radiofrequency, so there is reversible blockade and no permanent damage, and chances are of hypersensitivity afterwards are much less. Neurosurgically, there is very low quality evidence, although it does work and it has been published quite extensively. The quality of evidence is low. All procedures produce variable pain relief, but many may result in sensory side effects. There are no studies of microvascular decompression which observational data suggests gives the longest pain relief. So no randomized double-blind controlled studies for microvascular decompression, although it is known to provide the longest pain relief. There is little evidence to help with comparative decision making. So the surgeons basically choose what they want and what they like, or what they are familiar with, what they are trained in, and they go for those treatments. This is a picture of microvascular decompression. As you can see, this is the artery here, the trigeminal ganglion, and where it can and the branches which we are looking here. So we are looking at the branches going outside the skull from here, and the artery actually might compress one of those branches of the trigeminal. And what they do is they put a sponge between the artery and the nerve, so the sponge will absorb all the pulsations and not cause irritation of the branch of the trigeminal, which will provide pain relief. With the IF ablation, radio frequency, V2 and multiple division trigeminal nerve, less long-term pain relief. The third division, neuralgia, it can be expected to compare it with the isolated one. So even if there is immediate pain relief, it may not last for too long. To talk a little bit more, we are looking at the skull from above. Here we are looking at the cranium taken out, and as you can see, foramen magnum here and the gastric trigeminal foramen ovale is there in the anterolateral part. The trigeminal branches, I won't spend much time on that. Same thing again, branches of trigeminal distribution, and the complications are very important. And what I always teach is that first do no harm. So if you are going to give the patient more pain than the patient came in with, that is something that is not acceptable in any kind of medicine, especially in chronic pain medicine. So when you do the trigeminal interventions, there is a trigeminal cardiac reflex that can even cause possible asystole, and patient can go into cardiac arrest. So trigeminal radio frequency, patients have to have an IV started, continuous monitoring of the EKG or pulse ox, and as the pulse ox is not as reliable as EKG, EKG is the most recommended one that you have to monitor. The abducens nerve can also go into palsy after the procedure. There is sensory dysphagia, and that is one of the most horrible side effects or complications from radio frequency of trigeminal. Deafferent pain syndrome is the same thing as anesthesia. So basically, patient has pain over the part that does not have any sensation, and that is a central pain caused because of the lesion at the ganglion level. And a lot of doctors in India do radio frequency of the trigeminal without knowing all these consequences of what can happen to the patient, and they would end up making the patient's life more miserable than better. But sometimes patient may not have complications, not because the procedure was done, but because the procedure was not done right, or the nerve itself was not even lysed at all. And in a way, that is a blessing, because the patient may have temporary pain relief, but at least they won't have any long-term sequelae because of ganglion problems. A lot of doctors, and BOTOX, as we know, is going to block the neuromuscular junction. So muscles relax, and when the muscle, so the tension most responsive would be to the movement. But if you see the studies, 9 headache days per month, placebo has, so it doesn't give you a whole lot more. And it also depends on which muscles are involved, whether it is deep muscles, superficial muscle pain, that is again like a stress, which can lead to secondary myofascial pain. So the pain might itself be migraine, and that can cause myofascial pain and cause occipital headaches, occipital neuralgia, and that might be actually caused by migraine itself. So the FDA says that it has shown to be effective in the prevention of migraines, and that is why it is approved by insurance companies to use to relax the muscles. And when the muscles don't go into spasm, cause less pull on the periosteum of the cranium, causing less headaches. So they are given at an interval of 12 weeks as multiple injections or small amounts in the small areas of the muscle itself. And some of the newer treatments, one I guess, is the occipital nerve stimulation. There is also a spinopelvic ganglion stimulation that people have tried recently, and actually it was one of the questions in the WIP exam recently about one of the examiners wanted to try to know what the newest treatment for spinopelvic block was, and that was spinopelvic nerve stimulation. So by the stimulation, it actually works as a sympathetic blockade kind of treatment. And also, when you stimulate the occipital nerve, you are creating a tension in it like gate control mechanism, which can further lower the pain. So the results, actually, the studies were done mainly by Tim Deere, who is a very good friend of mine in North Carolina, I think, or no, West Virginia, sorry. And he has done quite a bit of studies on occipital nerve stimulation. Some of my other friends, Sam Naruz, who is actually the founder of American Interventional Headache Society, he also has done some studies on peripheral nerve stimulation for occipital nerve, quite effective. And Joe Jasper and Salim Hayek in Cleveland have done also some studies as well. So it is a useful tool that we use for chronic severe headaches of at least level 4 evidence based on multiple positive studies. And that means that it is limited because of the evidence, mainly because there are not too many studies done. There are no placebo-controlled studies because that would not be an ethical study. Once you place a device, you have to use it. And this is how it is placed. The are placed horizontally along the occipital nerves, the greater and lesser occipital nerve, and auriculotemporal can also be covered. It is looped around the spine, so the extension of the head and not let the electrodes move. And the stimulator itself is implanted just like a pacemaker at the top of the chest wall, lower down to the level of the waist. And so basically that is one of the newest treatments for the headache, occipital headache, or even migraine headaches, quite effective for that. And with that, I'm going to stop today. One of the very nice